Hello, class. Today we are going to cover various neurological injuries. Here are your module objectives, which are also located on your student version. Your spinal cord is a critical component of the central nervous system. It is going to extend from the medulla oblongata down into the lower back. And just like your brain, it consists of both gray and white matter. And it is going to have both a sensory and a motor tract, which is going to allow it to send and receive sensory stimuli and motor instructions. So it works as a channel so that the brain can communicate with the rest of the body. And certain reflexes, like our primitive reflexes, are going to be spinal reflexes, and they do not require any input from the brain. One of those is going to be that withdrawal reflex, like if you touch a hot stove. That does not require input from the brain. So in the clinical setting, a lot of times we'll have patients that they'll have like that little bit of withdrawal, but they could actually be brain dead, because brain death is the absence of brainstem reflexes. So it is still possible for them to have certain spinal reflexes. The communication channel between the body and the spinal cord is achieved because the body is going to contain 31 pairs of spinal nerves that are going to act as that communication channel between the body and the brain. You're going to have 8 pairs of cervical, 12 pairs of thoracic, 5 of lumbar, 5 of sacral, and 1 pair of coccygeal. A spinal cord injury usually results from the vertebrae or a penetrating object compressing, injuring, shearing, tearing, bruising that spinal column. It is going to cause damage to the bundle of nerves and those nerve fibers that are responsible for sending and receiving that sensory and motor input. Risk factors for a spinal cord injury include being a non-Hispanic white male. In fact, roughly 79% of spinal cord injuries occur to males engaging in risky behavior such as careless driving, not using appropriate protective equipment when engaging in sports, ATVs, motorcycles, especially when driving irresponsibly. And often this is going to occur in younger patients. In fact, about 47% of spinal cord injuries are going to occur between the ages of 16 and 30, and the most common age is 19. Now, although it tends to occur in younger patients, the average age at time of injury is 43 years old, because we got to account for the older patients who are going to develop spinal cord injuries as well. In the United States, there's over 18,000 spinal cord injuries that occur each year. Causes of spinal cord injuries can include trauma from like motor vehicle accidents, falls, diving in shallow water, gunshot wounds, traumatic force such as with sports injury, horseback riding, damage from bone fragments, shearing, tearing, bleeding forces. But the leading cause in patients under 65 are going to be motor vehicle accidents. And in patients greater than 65, it is going to be falls. Spinal cord injuries are often caused by compression to that spinal column. So you could have intermittent compression or a constant compression. You will also see transection injuries, are pretty common, and that's a type of tearing that is usually caused by spinal fractures. And you'll notice that any injury that can cause hyperflexion, compression, tearing, transection can lead to a spinal cord injury. Spinal cord injuries can be classified as incomplete or complete. An incomplete spinal cord injury is going to involve a partial loss of sensory and or motor function below that level of injury. And a complete spinal cord injury is going to involve complete loss of both sensory and motor function below that level of injury. We can also classify spinal cord injuries as either paraplegia or tetraplegia. You may be more familiar with quadriplegia, but apparently they're trying to kind of weather that term out and replace it with tetraplegia. So with paraplegia, the patient is going to, their lower limbs are going to be affected. They may have complete or partial loss of sensory and motor function. They may not be able to walk anymore. And this is going to involve your thoracic spinal column. So your T1 through your T6 is where you'll see the paraplegia. Now the tetraplegia is going to be loss of sensory function and motor function in all four limbs, and that is going to be indicative of a cervical spine injury. Now, with the spinal cord injury, you are going to have a primary injury, and that is going to be caused by the direct injury to that spinal cord, and it is usually irreversible. This can lead to death of neurons. Your axons can be demyelinated, and it can start an inflammatory process. Now, your secondary injury is going to occur as a consequence of those changes that are induced by the primary injury, such as your inflammatory response, the cascade. You may develop decreased blood flow due to damage or swelling, and that can lead to secondary ischemia. And this can lead to destruction of those nerve cells within that spinal column. And your secondary injury may or may not be reversible, depending on the underlying cause and how fast perfusion is resumed. There are various syndromes associated with those incomplete spinal cord injuries. You may see a central cord syndrome, and this type of spinal cord injury has a decent prognosis in terms of regaining at least some of the motor components of that spinal cord. And younger victims tend to have a much better recovery rate. Now, your anterior cord syndrome is going to have the worst prognosis for recovery. And these patients are often going to require long stints of rehabilitation. And unfortunately, only about 10 to 20% of victims are going to experience that motor recovery. Now, your Brown-Séquard syndrome is going to have the best prognosis, and about 75 to 90% of people will gain functional motor strength and will be able to eventually ambulate independently. And now your Canis modularis syndrome is a type of central cord syndrome, and these patients often experience a very poor prognosis for bowel and bladder function, like they may permanently lose their ability to control their bowels and bladder.
The survival rate for clients who have paraplegia is about 95.9%, and those with tetraplegia, it is about 91.2%. And life expectancy is going to be dependent on several factors, including the level of injury, the amount of function that is preserved, the patient's baseline health status, the patient's age, any existence of any comorbidities, how the injury affects the patient's mobility, their nutritional status. I mean, there's so many factors that can come into play. In many of these patients that are not wheelchair dependent and that do not require in and out catheterization will have a normal life expectancy. Now, spinal cord injuries can have such negative impacts on mobility. For example, patients who have a spinal cord injury at C4 and above will likely have a loss of movement in all extremities. Meanwhile, a patient who has an injury with C6 and above may have a little bit of wrist control and can use adaptive devices. Meanwhile, patients with a T1 injury, they're going to have paraplegia and some degree of arm and hand function. And patients who have injury at the sacral level can often walk with the use of assistive devices. And sometimes they can learn to ambulate independently if it's an incomplete spinal cord injury. Now, a spinal cord injury is a life-altering event, and it can have many psychological impacts on the patient and their family. And so it is important for you to assess all the psychosocial elements associated with spinal cord injuries. You need to assess for depression and anxiety, ineffective coping, thoughts of self-harm. And a spinal cord injury can actually lead to premature aging because it can affect their endocrine, cardiovascular, and musculoskeletal systems. And they're more likely to develop bone loss, chronic pain, kidney stones, as well as pressure injuries.
Now, I discussed prevention a lot in the first module on trauma, so I'm not going to dive too deep into it here. But just be aware that as a nurse, you are an educator, and you need to assess risk factors of different patient populations and provide them with education, because primary prevention is the best prevention. And you need to ensure that you are providing care that is appropriate for these patients and their risk factors. With older adults, you may need to educate them on fall precautions or initiate fall precautions while they're in the hospital, such as ensuring they have their call bell, that you have emptied their bowels and bladders, that their bed is at the lowest position. You want to educate patients about safe driving, using proper equipment, not engaging in reckless behaviors, like don't go jumping off the building into a pool or performing stunts on Jackass. Clinical manifestations are going to be highly dependent on the location of the spinal cord injury, as well as if an incomplete or a complete spinal cord injury has occurred. Now, your cervical injuries are going to be the most deliberating. They are going to be the most severe because this is at your cervical region, and everything below that area can be affected. This is associated with tetraplegia, and especially with your C4 and above injuries, your patients are going to have a loss of respiratory muscle control. They may have respiratory muscle weakness, and they are at great risk for respiratory compromise. You may notice autonomic dysreflexia, and that's going to be above your T6 and your above. You may notice things like bradycardia and hypotension as well in cervical spine injuries. Now, your thoracic spinal cord injuries can lead to paraplegia, and the degree of impairment is going to be dependent on where on that thoracic spine that injury has occurred. On the lower regions, like as I said a few minutes ago, patients may be able to eventually ambulate. Meanwhile, if it's an upper thoracic injury, they may only be able to have some degree of arm movement. So it's very dependent on that. Now, your patients that have those lumbar sacral injuries, a lot of times they will be able to eventually ambulate. But with this group, you have to think they have loss of bowel and bladder function, and they can have sexual dysfunction. And these are still life-altering dysfunctions for these patients. And there is a syndrome, and it is called cauda equina syndrome. And I see this a lot on NCLEX practice preps. And this is just a syndrome that occurs when the nerve roots in the lumbar spine are compressed. And this is going to affect the sensation and movement. And a red flag for this is going to be a dysfunction in bowel or bladder function, as well as altered sensation in the legs, lack of sexual sensation, and saddle numbness. These are telltale signs for the cauda equina syndrome. So remember that. Now let's go back to day 1. Emergency care for this patient population. Now, always start with your ABCs: airway, breathing, circulation. But remember, airway involves cervical spine stabilization. That is part of having a patent airway. Now, patients with a spinal cord injury can have additional neurological injuries. They may have a TBI, where we will need to do a GCS and a neurological exam. Remember, our GCS is going to range from 3 to 15, with 15 being alert and oriented times 4, no deficits, and 3 having no response to any stimulation. And remember, a GCS of 8, intubate, and a GCS of 8 or less is also indicative of a coma. Remember, with these spinal cord patients, it's very important that you use an appropriate spinal stabilization device, that you log roll them, and that you always assume a spinal cord injury is present until you are proven otherwise. You will see that imaging is the primary way to diagnose a spinal cord injury. You may see CTs, MRIs, or X-rays performed. And when a patient has a spinal cord injury, they may require surgery for stabilization of that spinal cord or for decompression of that spinal cord when compression is present. You will see that patients will often get a laminectomy, and this is going to be done to remove bone fragments, foreign bodies, or a hematoma. that is going to be placing compression on that spinal cord. And you may see surgeries to stabilize the spine. And then you may see spinal traction devices used, like that halo brace. W tongues are a type of cervical spine immobilization device where two sharp metal pins are screwed into the superficial layers of the skull, and they're going to be connected to hanging weights or some type of traction device to stabilize that cervical spine. And it is suggested that no more than 5 pounds of weight should be added per level of injury. So for a C5 injury, the max weight would be 25 pounds. This is a pretty temporary device. And for those patients who are going to require more longer term stabilization, they are going to require a halo vest. And with this, pins are going to be placed into the skull and torqued down into the halo ring, and a vest is applied which is going to connect to that halo ring. And this works better for those upper cervical injuries. And now nursing consideration. They'd love to ask questions about these traction devices, and I'd be like, oh my God, what is this? But for a patient with a halo fixation vest, only the provider adjusts the screws because it is going to require a special technique. This is going to require a special torquing wrench, and you need to make sure that it is located at the bedside. Now, nurses must ensure proper pin care is done 3 to 4 times a day to prevent infection. And this vest has a wool lining, so don't let it get wet. Don't use lotions or powders under it, and whatnot. There are various complications associated with spinal cord injuries, and with your cervical spine injuries, your respiratory complications and associated infections are of the leading cause of death for these patients. Respiratory complications can include atelectasis, pneumonia, a PE. So it is very important that you do meticulous respiratory assessments on these patients. Monitor their work of breathing, their respiratory rate and pattern. Are they using their accessory muscles? Are they showing signs of hypoxia? Other complications can include autonomic dysreflexia, neurogenic shock, spinal shock, pressure injuries, especially patients who are immobile and have poor nutrition. Other complications of spinal cord injury can include muscle spasticity. Patients with especially cervical spinal injuries are at a high risk for involuntary muscle movements. This can be quite distressing to patients, and it can cause them quite a bit of anxiety. Now, these patients are also going to be at risk for the development of contractures. Think about it. When we're not using our muscles, those fibers are going to shorten, leading to contractures. These patients may experience bowel and bladder dysfunction. They may develop neurogenic bladder. They may have problems emptying their bladder. They may have incontinence of both their bowel and bladders. Patients may develop constipation, ileus. They may suffer from chronic pain. And this, nerve pain tends to be atypical, and it's not responsive all the time to our typical pain relievers. So they may have to take something such as gabapentin or another type of anticonvulsant or antidepressant that we use for atypical pain. They may experience sexual dysfunction, sleeping problems, and all of these life altering things can be very, very emotionally and psychologically difficult for patients. Now I'm going to talk about the types of neurogenic bladder. Sometimes you will notice that your spinal cord patients may have a suprapubic catheter, and that is directly resulting from that neurogenic bladder. You can have that spastic kind, and that's where you're going to have that increased frequency, urgency. You're going to have that urine retention and that urge incontinence. Or you could have the flaccid neurogenic bladder. That's when you're going to have that overflow incontinence. And then you're going to have that sphincter incompetence, and you're going to be having urinary incontinence where you're having episodes of leakage. And neurogenic bladder can put the patient at risk for retention, a backflow or reflux of urine flow, which can cause a UTI, kidney infection, pyelonephritis, and lead to sepsis. It can be quite dangerous, and so we need to make sure that we are assessing the bowel and bladder function of our spinal cord patients.
What if I told you that this was the end of my presentation? Psych! But this would be a good time to take a mental break before I overload your brain some more. See you in a few. Autonomic dysreflexia is a potentially life-threatening complication seen in patients who have a spinal cord injury above the level of T6. And the higher the level of spinal cord injury, the higher the level of risk for developing AD. In fact, up to about 90% of patients with cervical spinal or high thoracic spinal cord injuries are susceptible to AD. And this is going to result from injury that leads to dysregulation of the autonomic nervous system, which is going to produce an uncoordinated sympathetic response that may result in potentially life-threatening hypertensive episodes when there is noxious stimuli below the level of that spinal cord injury. In about 85% of cases, the stimulus causing this hypertensive episode is from a urological source, such as a UTI, a distended bladder, or a clogged Foley catheter. AD can also result from fecal impaction, pressure ulcers, fractures, sexual intercourse, constipation, and surgery. Let me provide you with an example. An overdistended bladder is going to try to send a signal that it is full, but this signal is going to be blocked due to that spinal cord injury. And this blocked signal then causes a reflex action that is going to stimulate the autonomic nervous system to release catecholamines and to constrict blood vessels, causing a rapid increase in blood pressure. Now remember, we have those baroreceptors and chemoreceptors in our aortic arch and in our jugular that are constantly recognizing changes in our blood pressure. And normally they would be able to detect this increase in blood pressure and drive parasympathetic responses to combat it. Unfortunately, this signal is going to be blocked due to that spinal cord injury. So we're not going to have any compensatory mechanisms to help maintain homeostasis. So when that blood pressure is elevated, the patient's on their own. Their body is not going to help. And that's why you, as the nurse, have got to be able to recognize the potential for the development of this complication, and you have to act accordingly. Now, signs and symptoms of AD include hypertension. So if you have a patient with a high thoracic spinal injury or cervical injury, and the blood pressure is 150 systolic or more, or it's 40 millimeters of mercury above their baseline, I want you to start thinking, could this be autonomic dysreflexia? Other signs and symptoms can include a severe headache. A patient may be flushed and have profuse diaphoresis above that level of injury, while they may have cool, pale skin below that level of injury, and that's due to that severe vasoconstriction. They may have constricted pupils or pupillary changes. They may experience anxiety, numbness, bradycardia. And it is important that you can recognize these promptly, because this can result into pulmonary edema, a myocardial infarction, retinal hemorrhage, a hemorrhagic stroke, seizures, an acute kidney injury, and ultimately death. Now, your goal in treating autonomic dysreflexia is identifying and eliminating that triggering response. So if a patient is wearing tight clothing, you may want to remove that restrictive clothing. If a patient is experiencing bladder retention, insert a Foley. Encourage the client to void. If it is constipation, you may have to do disimpactment. So obviously you want to treat the cause, not the symptom, but sometimes you have to give the patient antihypertensives, and there are various antihypertensives you would administer in this situation. And you want to assist the patient in an upright position with their legs dangling if possible, because this can actually help drastically as well. Now, I want you to be that nurse that is always on the lookout, always on the prowl. I am so proactive. I would much rather prevent a complication than chase a complication. So prevention is key in autonomic dysreflexia. You want to monitor their indwelling catheter for adequate urine output. If they have a decrease in urinary output, is this an obstruction? Do they have an AKI? What's going on? You want to encourage the patient to regularly empty their bladder and bowels. Expect to administer bowel regimen medications. Obviously, you want to promptly treat UTIs. You want to start broad spectrum antibiotics. And then when the culture comes in, that is when you will narrow it down for that specific organism. You want to maintain a balanced diet for constipation prevention. You want to make sure they're having adequate dietary fiber. And you want to regularly reposition and assess the patient's skin and nails, because remember, pressure injuries can lead to episodes of autonomic dysreflexia. You want to encourage the patient to wear loose clothing. Don't wear your tightest pair of jeans and expect things to go well. You want to use sunscreen to avoid any type of sunburn. And you need to administer and educate patients about the importance of taking their prescribed medications that prevent AD complications. Neurogenic shock is a type of distributive shock that's most commonly caused by blunt traumatic injury to the spinal cord above the level of T6. But it can also be caused by Guillain-Barré syndrome, spinal anesthesia, transverse myelitis. But for the purposes of today, we are going to talk about it in relation to those high thoracic spine and cervical spine injuries. So we know that spinal cord injuries can disrupt that communication channel between the brain and the body. Well, neurogenic shock is going to occur from a loss of sympathetic tone in the blood vessels. So it is going to cause an unopposed parasympathetic response that normally our baroreceptors and chemoreceptors would recognize and promptly address by releasing those catecholamines, which will lead to an increase in heart rate, vasoconstriction. Well, unfortunately, because this communication pathway is altered, you are not going to have that normal compensatory response. So I want you to think of neurogenic shock kind of like the opposite of autonomic dysreflexia, because with autonomic dysreflexia, you are going to have that sympathetic activation, but you're not going to have that parasympathetic response, that compensatory mechanism to come into play. And this is the opposite. So patients are going to go into distributive shock. It is going to be marked by increased vasodilation. Now, since we're talking about the parasympathetic nervous system remaining active, patients in this type of shock will be bradycardic, because remember, it's that sympathetic nervous system that's going to increase that heart rate. Now, just like with all other types of shock, this is going to ultimately lead to hypoperfusion, cellular hypoxia, and damage. Other causes of neurogenic shock can include TBIs, insulin reactions, administering CNS depressants, anesthesia, and whatnot. And also, something very interesting with this type of shock, these patients have trouble regulating their temperature mechanism in their hypothalamus, and they can actually have something called poikithermia, where they can actually start taking on the temperature of their external environment. That's pretty cool. I've seen it. It's not cool to treat though, because it's a hot mess. One minute they're starting to get warm, you warm them up, and then suddenly they're hypothermic again, so then you go to warm them up, and then they're hypothermic, and it can be very difficult to manage. Treatment for neurogenic shock can include fluid resuscitation to increase that preload. You may see vasopressors used. Norepinephrine is going to be the first-line agent for neurogenic shock, and that is going to increase that systemic vascular resistance. You may see inotropes used. This is one of the few times I will actually say you will see dopamine used, because think about it, dobutamine dilates arterioles, which will help perfuse the coronary arteries, like with a post-myocardial infarction or whatnot. But we don't want to dilate those arterioles here. We just need that inotropic effect. So a lot of times you'll see dopamine, and remember, epinephrine at low doses functions only as an inotrope, and at higher doses, that's where you can get that alpha or that vasoconstriction effect. So you may see epinephrine used instead of dopamine. Kill two birds with one stone. You may see atropine used to treat bradycardia, as long as it's not a third-degree heart block, because atropine is not going to work there, and likely it will not result in a third-degree heart block. You generally want to keep your MAPS a little higher in this type of shock. You want to keep it anywhere from like 85 to 90. And you want to treat any underlying cause, for example, spinal alignment or surgery, to alleviate that spinal compression. And this type of shock can last for several weeks. And another one of your goals is going to be to prevent that hypoperfusion and ischemia, so that you do not cause a secondary spinal injury or exacerbate that secondary spinal injury due to poor perfusion. It is very easy to confuse spinal shock with neurogenic shock because both of these are going to be vasogenic states, and patients with these conditions will present with similar clinical manifestations. But they have different etiologies, and there are some key differences that will allow you to distinguish between the two. So your spinal shock is a reversible and transient impairment to spinal cord function. And this is usually going to be directly caused by that primary injury, so direct trauma to that spinal cord, even though this can result from secondary injury as well. So because this usually occurs from the primary injury, it is going to generally occur immediately to a few hours after the initial injury. So there will be an absence of motor and sensory function below that level of injury. Patients will have areflexia. So upon physical assessment, you may notice the deep tendon reflexes are absent, as well as the cutaneous reflexes. These patients are not going to have any control over their bowel or bladder function. And you will notice that their muscles are flaccid and the patient will appear paralyzed. And this can actually cause the patient to appear more severely injured than they actually are. And I want to point out that shock, when I say spinal shock, this is not related to a state of circulatory collapse like with your other types of shock. And the reason we call it shock is because you have those suppressed spinal reflexes below that level of injury. So that is what we are referring to in terms of shock. Now, just like with your neurogenic shock, it is very important that we try to keep the MAP greater than 85 because we want to make sure that we are adequately perfusing the spinal cord to prevent any secondary injury, to worsen secondary injury, and to meet those increased oxygen demands of the spinal column. Now, these patients may present with hypotension and bradycardia, just like your neurogenic shock, and that has to do with we have lost that sensory function of our spinal cord. So there is not going to be that communication pathway between that parasympathetic and sympathetic nervous system. So the patient will be in that parasympathetic state, and there's no way to send that sensory information to the brain, to the hypothalamus, so that the sympathetic nervous system can be activated. So you will see a lot of those similarities. And spinal shock can last for a few weeks up to about a year. And it can be a very delayed process to where at first you'll have those absent reflexes, and eventually you'll get, your cutaneous reflexes will start to return. You might take longer for those deep tendon reflexes to return. Patients may have that Babinski sign. They may have hypotension that can last for several weeks. And at any point, they can actually develop autonomic dysreflexia and neurogenic shock. Now, the key difference in the manifestations between neurogenic shock and spinal shock is related to the fact that neurogenic shock is a state of hypoperfusion and tissue hypoxia, aka shock. And spinal shock is not a state of hypoperfusion and tissue hypoxia, although it can lead to one. But this is a state of shock, and I say that in quotation marks, because there is that disconnection between the spinal cord and the reflexes. So this is not true shock. Now, we do need to treat any of the manifestations that the patient presents, like the hypotension, the bradycardia. We do need to treat those as well, because we have lost that sympathetic tone, and we need to make sure that the patient is hemodynamically stable. We'll see a variety of different types of medications used in patients with spinal cord injuries, and a lot of them are going to be used depending on the type of complications that arise from the patient's spinal cord injury. Now, remember, autonomic dysreflexia is that activation of the sympathetic nervous system that occurs from that noxious stimuli. And since we have that disruption in the communication pathway between the body and spinal cord, we're not going to have that compensatory parasympathetic response. So these patients are going to have very high blood pressures, which can be dangerous. It can actually increase their chance of a stroke up to 300%. So it's very important that we eliminate the cause of the response, but a lot of times we will have to administer antihypertensives, calcium channel blockers such as your nifedipine. You may see ACE inhibitors, ARBs, hydralazine, so direct vasodilators. And you may see a drug called prazosin, and this is a antihypertensive, but it's also used off-label to help with sleep disturbances in patients with post-traumatic stress disorder. You may see antibiotics used. Patients with spinal cord injuries are at increased risk for urinary infections due to their bladder issues. The ones with the higher thoracic and cervical spine injuries are at high risk for pneumonia. And anytime our body is under any type of stress, it is going to decrease our immune system function, and we are at a higher risk for the development of secondary infections. Now, there's a variety of different medications we can use to treat that muscle spasticity. You may use muscle relaxants such as baclofen. You may see benzodiazepines such as diazepam used. You can see anticonvulsants such as gabapentin. Now, gabapentin, it's only on label or FDA approved use is for seizures and fibromyalgia, but you'll see that it's used 95% of the time to treat like that neuropathic pain. And a lot of times patients with spinal cord injuries, this can kind of help with that spasticity as well. Now, you will see other medications used to treat pain. You may see chronic pain. These patients may develop, pain from muscle wasting, from various aspects of this disease process. So you may give them NSAIDs if their kidney function is normal. They may start receiving opioids, skeletal muscle relaxants, and that is kind of like, let's treat the source of what's causing the pain. We often use antidepressants to treat atypical pain, same as gabapentin. Depression is very common in this group as well. You may see SSRIs, SNRIs, or TCAs. Other meds are going to include stool softeners, laxatives, because remember, patients with autonomic dysreflexia, if they have constipation, that can actually trigger that response. So we want to treat that underlying cause. Patients may require fluids depending on what's going on, like with neurogenic shock, you may want to increase their preload. Patients with spinal cord injury are going to be at a high risk for the development of a venous thromboembolism. So you will probably administer like anticoagulants such as heparin, Lovenox. Now, patients with neurogenic shock, they are in a state of shock, so you may need to use vasopressors. Your first line vasopressor is going to be norepinephrine. You may use phenylephrine. And remember, epinephrine has vasopressive effects at higher doses. You could actually use that, but that's definitely not first line. Inotropes, you may use that dopamine or epinephrine. You may need to use atropine to increase that heart rate if the patient is normotensive. Although spinal cord injuries are more common in white males, they can occur in anyone at any time, regardless of their age, ethnicity, lifestyle choices. So it's very important as a nurse that you are aware of this and that you understand that there are certain factors about each patient population that are going to affect that patient population's individual needs, as well as any challenges that may arise. For example, pregnant women, although, having a spinal cord injury can affect sexual function and it can lead to infertility, but pregnant women can still become pregnant. Now, remember, pregnancy alters our normal physiology in the body. It is going to change our cardiac output. It is going to change so many things. So we need to remember that when we are planning care for these spinal cord patients. For example, pregnancy is already puts a woman at risk for the development of clot. Pregnancy itself is a hypercoagulable state. However, a spinal cord injury can exacerbate that, especially when there is extreme impairment to mobility. Now, pregnant women are at a much higher risk of developing complications such as that autonomic dysreflexia and neurogenic shock. But we need to take special consideration when treating these because a lot of the medications that we give may be tetragenic. And so we have to look at the overall picture. Vasopressors, she may require them, but that can decrease the interplacental oxygen. That can lead to insufficiency. Or certain medications we give for hypertension that are ideal for spinal cord patients with AD, we may not be able to give. And remember, pregnancy is going to change every body system in your body. It alters your cardiac output, your respiratory function. So we need to consider all of that. Now, younger people are at a high risk for the development of spinal cord injuries. About 20% of spinal cord patients are between the ages of 10 to 19. So that's going to include our older children, our adolescents, and our very young adults. And a lot of times when injury occurs prior to puberty, this can lead to sequelae such as scoliosis, even if the spinal cord injury was recoverable. Now, a lot of time, the adolescents are going to be less compliant. For example, just imagine a 15-year-old girl going to school with her halo vest on. I can't even imagine how that would go. Or they don't fully understand the long-term consequences of their injury and the prognosis. Or that is a way for them to cope. And adolescents do not cope in the same way that adults do. And these adolescents may be at high risk for depression, suicide, and you need to look out for certain changes in behavior, such as lashing out, withdrawing, and things of that nature. Now, older adults, falls are the leading cause of a spinal cord injury, so initiating those fall precaution, assessing the patient's gait, and then we need to look at the overall picture, the presence of comorbidities, and the quality of life when making decisions in regard to surgical intervention, rehab, and life-prolonging decisions. That is definitely a multidisciplinary approach, and it can be definitely some really hard conversations you will have as a nurse. A traumatic brain injury is a very non-specific term that describes injury to the brain parenchyma. And this can be caused by a variety of different mechanisms, such as a skull fracture, with the basilar skull fracture being of the most dangerous because that's located at the base of the skull and the brainstem is at the base of the skull. So patients with the basilar skull fracture are at very high risk of brainstem herniation, compression of that brainstem. And remember, basilar skull fractures, that's where you may have like the raccoon eyes. You may have that CSF leakage from the ear or nose. When you see that type of clear drainage, you get a glucometer and you see what that glucose reading is. You may also see that bruising behind the ear, and that is called that battle sign. And remember, with your basilar skull fractures, you do not place an NG tube. You would have to do an oropharyngeal tube. You cannot place an NG. It's contraindicated. Patients may have penetrating injuries, concussions, contusions, hematomas, hemorrhages, diffuse axonal injuries, and that's going to be those shearing and tearing injuries to the axons, which you see a lot of times in motor vehicle accidents with your motorcycles as well. And remember, your TBIs can be local, like with your coupe, contra coupe accidents. Remember, coupe is where you hit your head on the steering wheel, for example, and then as your neck goes back, you're going to hit the opposite side of your brain on the back of your skull. So you'll have two localized injuries. So as you can see, I could go on and on about the different mechanism of injury, but just know that shearing, tearing, bleeding, cerebral edema, any of that can lead to injury to that brain parenchyma. Now, TBIs are going to be categorized as mild, moderate, or severe. A lot of time your mild are going to occur with the less severe types of injuries, such as a bicycle accident, or you fell rollerblading and hit your head, or some of your sports injuries where they've developed like a concussion. Most of the time the patient will not lose consciousness, and if they do, it'll be very brief, and generally you will not see any injury on any type of neuroimaging. Now your moderate TBIs, that is often going to be like your non-penetrating blows to the head, and patients may be unconscious for up to about 24 hours. It can be a little longer, and you will see some signs of injury on that neuroimaging test. Now your severe TBIs, that's going to be like those gaping head wounds, penetrating, crushing blows, and unconsciousness can occur much longer than 24 hours. It could actually be indefinite, and you will see some pretty significant injury on those neuroimaging exams. And our TBIs can lead to various other complications such as cerebral edema, brain herniation, and brain death.
Intracranial pressure is the pressure exerted within the intracranium by our circulating CSF, our intracranial blood flow, and the brain parenchyma itself. It is impossible to talk about intracranial pressure without discussing the Monroe-Kelly doctrine. This has been our fundamental principle behind ICP for over 200 years. And according to this hypothesis, the sum of our brain volume, our CSF, and our intracranial blood flow is constant. And an increase in one of these components should cause a decrease in one or both of the remaining components. And this is what keeps intracranial pressure near constant levels. And when we have an increase in the volume of one component, that is going to require a decrease in the other components, because if not, we are going to have increased intracranial pressure. So this doctrine is just describing the compensatory mechanisms that are occurring within the intracranium. Because if this was not the case, things that we do, such as having coughing spells and signs and symptoms of increased intracranial pressure, may be very mild to severe in nature. Now, your first sign of increased intracranial pressure is always a change in mental status, unless the increased ICP is caused by an epidural hematoma, which is a type of intracranial bleed. And a lot of times you will see a pupillary response prior to that change in mental status. And that just has to do with the location of the bleed and how it can compress on that oculomotor nerves. Now, you may notice pupillary changes. You may notice dilated pupils. You may notice constricted pupils. You may notice one pupil is larger than the other. You may notice that you have sluggish or non-reactive pupils. Other signs and symptoms can be a headache. A patient may start developing seizures. And you may notice some neuromuscular changes, such as patient may become very flaccid, in some cases rigid. You may notice changes in speech. A patient may begin vomiting. A lot of times you'll see projectile vomiting. And now you may see that abnormal posturing. Remember, your decorticate is less severe. It's usually a sign of damage to the cerebrum, but this damage can extend into the brainstem. That's going to be that normal flexion where they bring their muscles into the core of their body. Say decorticate, they're trying to hang on. Now, you may also see decerebrate, which is definitely a lot worse. And it is more common to see this. And with decerebrate, that usually means that there's damage to the deeper structures of the brain, such as the midbrain, the diencephalon, and definitely certain parts of that brainstem. And with this, they are letting go. So what they're doing is they're extending their extremities outward. Another manifestation you may see, and this is a sign of impeding uncal herniation, and that is where your brain, there's so much pressure within it that it is going to move downward into that foramen magnum and compress on that brainstem. That is going to cause brain death. And when you have something called Cushing's triad, that is a sign that you are going to have impeding doom. And you will notice that the patient is going to have an increase in their systolic blood pressure, so they're going to have systolic hypertension with a very wide pulse pressure. It's like the opposite of the cardiac tamponade. Remember where that pulse pressure is very narrow? They're going to be bradycardic. And then you're going to also notice an irregular respiratory pattern. And this means that you are in trouble. Your intracranial pressure is through the roof and you need to act quickly or brain death will occur. Now, infants, their signs and symptoms of increased intracranial pressure may be a little different. You may notice that bulging fontanelles. Remember, they have those fontanelles. So their brain actually has a little more room to swell. You may notice that there's an increase in their head circumference. They have that high-pitched cry. Projectile vomiting can occur with them as well. We have 12 pairs of cranial nerves that extend from various parts of the brain, including the brainstem. And some of these cranial nerves have motor function, and some have sensory function, while others are going to have both motor and sensory function. And you will see that assessment of cranial nerve function is a routine part of neurological assessments. For example, you will see us assess cranial nerve 3 by doing a pupillary exam, the cardinal fields of gaze. We will test for pupillary response and accommodation. And this is just one of the various cranial nerves that we may test during a neurological exam. You will use various medications to treat intracranial pressure and to help with supportive care for patients with high ICP. One medication you may administer is going to be mannitol. Mannitol is an osmotic diuretic, and this drug can also be used to treat intraocular hypertension in patients with glaucoma when they are having an acute change in their intraocular pressure. Now, this medication is going to work by inhibiting sodium and water absorption in the kidneys. And mannitol is going to promote fluid movement from the intracellular to the extracellular space. So basically, it is going to dehydrate the tissues. It's going to pull that fluid out. So now the brain tissue is going to be shriveled and dehydrated. Remember that Monroe-Kelly doctrine? What we're doing is decreasing that fluid amount around the brain, so we're shrinking that brain parenchyma. Now, with mannitol, it is a very high-risk drug and it is not used very frequently, usually only in emergent situations. And this can cause intracellular dehydration, and it can cause fluid overload and edema. Remember, you're going to be pulling that fluid out of the cells, and it's going to be going in the extravascular space. So some of it will be in the interstitial space, so you may see some edema, and then some of it's going to go into the vascular space. So you may see like CSF exacerbation because now you have fluid overload. It can lead to things such as pulmonary edema because it can get into that lung interstitium. This medication can crystallize, especially at colder temperatures, so you will use a filtered needle to administer it. It can actually cause hypertension because we're going to increase that preload significantly and overload that cardiovascular system. Mannitol, it can cause electrolyte abnormalities. It can cause hyperkalemia. It's going to pull that potassium out the cell. It can
move it to the interstitial and intravascular space, causing your serum potassium to increase. Other medications you may see for patients with increased intracranial pressure can include antipyretics like Tylenol. Obviously, when we have a fever, that is going to increase the metabolic demands, and it is going to cause vasodilation. Two things that we do not want in our neuro patient. So a lot of times in these patients, we will go ahead and treat fevers prior to the patient developing a pathological fever. For example, we may often give Tylenol when the patient reaches the temperature of 37.5 Celsius. Or you may see that Tylenol is administered around the clock. Now, with our intracranial pressure patients, we want to find that perfect balance between having an adequate map so that we have appropriate cerebral perfusion pressure while not causing too much pressure. So we need to find that balance between what blood pressure is appropriate and when we need to treat it. A lot of times we will allow some permissive hypertension just so we can achieve our MAP goals. You may administer vasopressors because, and I'll get to it more in the next slide, but we want to maintain our cerebral perfusion pressure, and that is going to be dependent on our ICP. So when we have an elevation in our ICP, we may need to have a higher MAP to make sure that the brain is still getting appropriate blood flow. You will often see GI prophylaxis administered in these patients because, a lot of times they're going to be laying in bed for a long time. They can get stress ulcers. They may be intubated. You want to avoid aspiration and ventilator-associated pneumonia. You may see anti-epileptics used. Think about it. When you have increased intracranial pressure, you're going to have irritation to those axons, to your neurons, and guess what? They can get really excited, and that increased neural excitability can lead to things like muscle spasticity. It can lead to things such as seizures and myoclonus. So we may administer these medications. Now, phenytoin is not used so much in the clinical setting as often anymore because there's more effective drugs that have less side effects. A lot of times you'll see Keppra, but in NCLEX world, that is still a major thing, and you will see it in the clinical setting. It's not one of those drugs like MAOIs that you tell me if you find one. I'll give you $100 if you can find someone on an MAOI. But phenytoin is a medication that comes with a lot of risk. It can be very hepatotoxic, so you need to watch for signs and symptoms of liver dysfunction. It can lead to the development of a lymphoma. It can be very toxic, and it has a very narrow therapeutic range. So we will have to monitor the levels according to the facility policy. And things like altered renal or altered hepatic function can cause interference with the dosing, scheduling, as well as with the frequency of how often you have to monitor. Now, stool softeners can be given because when a patient is straining and bearing down, that can actually lead to increased intracranial pressure. And a lot of the medications we are giving in that ICU are going to cause constipation, like fentanyl, all of your central nervous depressants. Then a lot of times, there may be a delay in feeding the patient. The patient may develop conditions such as gastroparesis, where they have that delayed emptying, and this can lead to a multitude of problems. So we want to make sure that we are promoting adequate bowel functioning. Now, IV fluids. A lot of times you will see that neuro patients, they might actually even want them to be slightly hypovolemic. because they are concerned that with that hypovolemia, you're still going to have increased fluid in your extravascular space. So they don't want to have increased fluid. Now, most of the time you'll see that they want the patients to be like euvolemic. So they just don't want large amounts of volume. And as far as your IV fluids, you never, ever, 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 ever give a hypotonic fluid to this patient population. You don't give D5, even though it's isotonic, because remember, your body is going to metabolize that sugar immediately, and then you're going to be left with a hypotonic solution. And you don't want to give lactated ringers either. That can actually lead to cerebral edema. There is only one isotonic solution that is appropriate, and that is going to be your sodium chloride. You may also give 3% saline, and this is going to work by pulling the fluid out of the cells, and it can lead to like cellular dehydration and whatnot. So we're going to shrivel those brain cells. And it can also cause the cerebral spinal fluid to shift from that column, leading to a reduction in both the blood parenchyma as well as the CSF Monroe-Kelly doctrine. So a lot of times these patients with high ICP, you may see that their sodium goal is 145 to 155, which is high. We may want to induce a little hypernatremia so we can cause that shift of CSF fluid and that cellular dehydration.
One of the easiest and most effective ways to decrease ICP is by letting gravity do the work for you. So, ensuring that the patient's head of bed is at least 30 degrees is a quick way to decrease ICP. And that's going to go back to the Monroe-Kelly doctrine. Remember, an increase in blood flow? So what we're doing is we are manipulating the head of the bed to decrease that blood flow to the brain. Another intervention is going to be maintaining the head and neck midline. You don't want to hyperextend the neck. You don't want to have the neck or head tilted. You want to maintain a proper airway for the patient. You want to make sure that it's patent and that the patient is breathing and ventilating appropriately. And you want to avoid any type of hypoventilation, because remember, hypoventilation is going to increase your carbon dioxide. And when we have an increase in carbon dioxide, that is going to lead to vasodilation. And we don't want vasodilation. We don't want them vessels in our brain to get dilated, right? And you want to promptly treat any pain or discomfort. You also want to promote a calm and quiet environment. So you want to reduce stimulation. And you want to educate the patient's family members about overstimulating the patient. You may have to sedate the patient because environmental triggers may cause too much anxiety. And obviously, you're only going to sedate them if they are intubated. You want to make sure you maintain that normothermia. So you may have to apply cooling device or ice packs. Because remember, when we have a fever, that's going to cause vasodilation. And the last thing we want is those vessels in the brain to get larger. That is going to exacerbate that increased intracranial pressure. You may see that surgical intervention may be needed if a patient has a subdural hematoma. And in some situations where intracranial pressure is so high, depending on the cause, you may see them do a craniotomy.
Now, patients with increased intracranial pressure, you always need to make sure that you're supporting their ABCs. These patients may be incapacitated. They may not be able to protect their airway. They may have neurological function, which can ultimately affect brain function. Remember, your respiratory center is in your medulla oblongata in your brain. You want to minimize any further damage by maintaining ICP. And you want to make sure that you are promoting adequate cerebral perfusion. Now, remember, your normal ICP is generally 5 to 15. Normal CPP is anywhere from 60 to 80. Some sources have it 50 to 100. Just remember, that's just a range. Now, your cerebral perfusion pressure is just the net pressure gradient that drives oxygen delivery to the cerebral tissues. Now, remember, when you have an injury to a part of your body, that's going to increase its metabolic demands. It's going to increase its oxygen demands. So we want to make sure that we are keeping the cerebral perfusion pressure high enough to meet these increased demands. But if CPP gets too high, then this may increase the intracranial pressure. And since this is a math equation based on your MAP and your ICP, if you have a high ICP, your MAP needs to be higher to incorporate this change. For example, normal circumstances, my MAP is 65. My ICP is 5. I have a CPP of 60. That's appropriate. Now, let's say my MAP is 65, but my ICP is 15. So 65 minus 15. Now suddenly my CPP is only 50, and that's not appropriate. So when I was talking about we may need to administer vasopressors to keep the patient's MAP higher, that is why, because that increase in ICP, we need to subsequently increase that MAP to keep that same CPP. Now, we got to always find a balance. You don't want the patient's blood pressure 190 when they had a brain bleed. No. But you need to find that perfect balance. Patients may require an intraventricular drain, which is going to be an ICP monitoring and CSF drainage device. And they will require very close hemodynamic monitoring. You always want to keep that bed greater than 30 degrees or reverse Trendelenburg. You may need to put that sign up that says do not touch the head of the bed without talking to RN. I always have that sign up, or I'll even put up that decreased stimulation sign, so hopefully the family will chill and not be blasting Wheel of Fortune and all up in the patient's face, poking at him. Why is his blood pressure like that? Because you won't get out of his face. You want to initiate those seizure precautions and provide supportive care. Normal intracranial pressure is 5 to 15 millimeters of mercury, and when intracranial pressure increases to greater than 20 millimeters of mercury and it sustains like that, a patient is at great risk for secondary brain damage from that increased intracranial pressure. Because think about it, what's going on is that brain is being compressed, and this can lead to herniation. And I actually have added a picture of different herniations. There are several that can occur. Most of the time when you hear the word herniation, most people automatically think of that uncal herniation, that central herniation, where your cerebrum is so compressed that it goes down into the foramen magnum, and it is going to compress that brainstem and lead to brainstem death. But a herniation, there's several types. It can be any type A herniation just means brain tissue is moved to somewhere where it's not supposed to be. When we see those strokes with those midline shifts, that's a type of herniation, and that's the most common type of herniation. I just wanted to kind of show you that because the brain can move in all these different directions as a result of that increased intracranial pressure, because unlike babies that have that fontanelles, the brain tissue has nowhere to go except through those foramen magnum, like those holes in the skull, and that's what can lead to that brain death. Now, there's going to be various different indications for intracranial pressure monitoring that could include trauma to the brain, and you can see this on a CT scan or MRI if your GCS is less than 8 and we have suspected head trauma. Another indication would be hydrocephalus and intercerebral bleed. Rye syndrome, which can lead to cerebral edema. That's why we don't give the kids aspirin with viral symptoms, and we don't give them Pepto as well, because that can lead to Rye syndrome, which is characterized by cerebral edema. In emergent situations, you may see a decompressive craniectomy performed, and that's where they are going to remove a piece of the skull to allow for that brain to expand without compressing it. And something really cool about that is when they remove the skull, they're going to place it in this compartment in your abdominal cavity, and it's just like chilling there until they put it back. And this could be months and months down the road. And that's when you'll see the patients with the helmets. They had a craniectomy, so they're missing a part of their skull. That's why they need that helmet. So be nice. They used to joke about me and say I needed a helmet, and I'm like, well, I got all of my skull, so thanks. Now, there's various contraindications for this, such as severe brain abscesses, patients that have severe coagulopathies. Sometimes brain abscesses or survivability will be considered as well. So just know that there's various tools we use, and I'll discuss some of your invasive tools in the next slide, but I'm not going to go into detail. Now, I don't expect you to know like these specifics on these various ICP monitoring systems, but I do want you to know that we use these systems to help manipulate that CSF or blood volume when we have increased intracranial pressure. Wait, I think I've heard something about this. Monroe-Kelly doctrine. You see, that is going to be the foundation of all of our interventions. Now, the most common one you will see in your clinical settings will probably be the intraventricular catheter, an EVD. And this is an invasive monitoring device that is going to be placed between the fourth ventricle and the lateral ventricle, I think, if I remember correctly. Yeah. And that is where the bulk of your CSF is going to be produced. And the external landmark is the tragus. So we are going to have a monitoring and a zeroing device. So we're going to use that tragus as the reference point when we zero the device, because that's going to be the external landmark equivalent to the area inside the brain where that CSF is produced. Now, let's see. You can only monitor the ICP or drain at the same time unless you have a separate device that allows you to do both, like the Codman. And like I said, this is going to make no sense, so I'm not going to harp on it. But just know that with these patients, you need to do meticulous neuro assessments. You need to make sure that if the head of the bed is adjusted, that you re-level and re-zero your device. because you want to make sure that it is calibrated appropriately. You want to notice any changes in your patient's neurological exam, and you may want to clamp this device when laying the patient's head flat, and you just have to make sure that you unclamp it appropriately. And this device can help keep intracranial pressure within normal limits, and it can be life-saving.
Injury to the body is going to cause a state of hypermetabolism and increased catabolism. So, when a patient develops a TBI, they are often going to experience those complications of hypermetabolism, such as protein wasting and increased energy demand, hyperglycemia. And remember, protein is such an important macromolecule for healing. And if our supply of protein does not meet our increased demand, the patient will go into that negative energy balance. And this can ultimately affect skeletal muscle and cause many additional complications. So it's important that patients with a TBI have adequate protein. We want to make sure that anywhere from 15 to 20% of their calories are going to come from protein. And so, because of this, we need to begin early gastric feedings for our intubated patient. We want to make sure that we are giving them the tools for them to heal. And remember, a lot of our neurological patients are going to develop gastroparesis. And remember, that's just delayed gastric emptying. And this can result from injury to the autonomic nervous system, sedatives that we give the patient, pain medications, and the fact that we're just laying in bed, and that's going to decrease that gastric motility. For patients who have had a TBI, it's important to meticulously monitor their glucose and to treat hyper and hypoglycemia promptly. Often, we will allow some permissive hyperglycemia, and that is often due to increased glucose demands of the brain. So, a lot of recommendations state that we should only treat glucose over like 218 milligrams per deciliter. And each hospital will have a different policy, but you don't want to have such strict glycemic control to where the brain is not getting the demands.